Good morning, and thank you for joining us for our webinar that will discuss tools for performance improvement in hospital-owned practices. My name is Vicki Radcliffe, and I will be your moderator today. Before we get started with our presentation, bear with me as I review a few general reminders and instructions for our audience. If you're experiencing any issues getting online for the presentation, please call the Integrated Healthcare Strategies front desk. They may be able to assist you. That number is 612-339-0919. Be aware that there are two ways to join the audio portion of this webinar. You can dial in directly to 1-866-809-9263 and then use participant code 610-285-8791. You can also see that up on your screen right now. Or you can have the system call you. You simply click on the voice and video menu box and then click the join audio button. You'll be prompted to put in your phone number, and the system will call that number directly. Please be aware that all participant lines are muted for the entire presentation to reduce noise and distractions from the line. At the end of our presentation, we will allow time for questions and answers, though, and if you have a question you would like addressed, you may type it in and we will read it for you, or read it off and then our presenters will answer for you. To do so, you simply click on the Q&A button on the menu bar at the top of your screen, type in the question, click the submit button, and that'll get directed to us. Following the webinar, as a reminder, all participants will receive a copy of the presentation. Our presenters today are Dr. William Jessee, Senior Vice President and Senior Advisor, Chuck Gooder, Senior Advisor, and Tony Kouba, Senior Consultant with Integrated Healthcare Strategies. With that, I'll go ahead and hand it over to Dr. Jessee.
All right, Vicki, thanks very much, and good morning to everyone on the call. This is the third in our series on how to make hospital-owned practices work more effectively. But I thought we would just start off by very briefly reminding everyone of the breadth of services that are available from Integrated Healthcare Strategies. Most of you either are or have been, or we hope will be, clients of ours. Many of you probably think of us as a firm that does a lot of work on executive compensation and benefits consulting, but this slide shows that we've really broadened the scope of our services considerably over the last few years. As more and more hospitals employ more physicians, we're doing a great deal of work on physician compensation and benefits. And as more incentive compensation begins to reach down into the middle management ranks, we've helped a number of clients with that. We also do executive search, do a variety of human resource consulting, including labor union work. We do surveys of compensation and benefits. Increasingly, we're doing more surveys of employee opinion and physician opinion and engagement. We've developed some fascinating new tools for measuring the degree to which various populations of physicians in your hospital are really engaged in trying to support your strategic direction. And then the last couple of areas, governance and physician leadership development. We do a lot of work now with boards trying to help them improve their governance oversight, and on physician hospital integration and operations. And that really is the area in which this webinar falls. Our client base, as many of you probably know, is quite extensive. This is just sort of a random representative sample of some of the blue chip clients that we serve. But collectively, the company serves about 1,200 primarily not-for-profit hospitals and hospital systems around the country. So that's a little bit about the company. Today's webinar has 5 objectives. First, to learn how to use comparative benchmarking information to improve clinical performance in hospital-owned practices. Second, to help you understand how your hospital-owned practices compare with carrier conversion factors, FTE provider performance standards, and necessary staffing for FTE provider. To get an overview on trends that will help you improve the bottom line. To learn how to develop a position on healthcare reform and understand how quickly that's likely to affect your market and therefore you as well. And then finally, to understand the correct provider mix to meet the service needs of your community and the method and scope needed to attract new patients. So that's sort of an overview of our objectives. As I mentioned earlier, this is the third in a series of 3. The first of our webinars on this topic was back in January, where we talked about 22 questions to ask before you acquire a physician practice. And if you're interested in that webinar is still available through our website. You can access it on demand. We followed that up with a second webinar talking about the importance of trying to accomplish 2 things in hospital-owned practices: how to take a practice that you may already have purchased, whether or not you've asked the right 22 questions, That's one of the pieces of feedback we got from the first one is gee, I wish I'd asked some of these questions before we got as deeply into practice ownership as we are. But given that many hospitals own a lot of practices, I think the national numbers that I've seen are about 25% of the physician population now is employed by a hospital, and that number continues to rise each year. So it becomes really important to try to maximize the value that the enterprise receives from those owned practices. And we've really taken it down to the essentials. Two key factors in success in hospital-owned practices. First, a clear strategy. And it has to be a strategy that's got broad buy-in from your board, from your executive team and physicians. I often see hospitals that have a strategy, but they've not communicated it to the physicians. And it's a little bit like a football team developing a game plan but not telling the players what it is. If the physicians don't know where you're trying to go, they're not likely to be helpful in getting you there. So having that clarity on strategy and that buy-in from all the key players is critical. And then once you've got the strategy, then flawless execution of practice operations becomes the second key factor. And that's going to be the focus of today's webinar. Just a quick word on the strategy. If you haven't answered these questions in your own organization, I would suggest that it's really important to do that. But where are you trying to go with investment in physician practices? What is your overall reason for strategic reason for investing in physician practices? And then applying that overall strategy to each individual acquisition. What are your strategic objectives driving each particular practice that you acquire and physicians that you employ? Then I mentioned earlier, is there buy-in to the strategy from board, management team, and key physician leaders? Not only the physicians and the practices you acquire, but the leadership of your medical staff and other potentially competitor physicians who may feel that they're being disadvantaged when the hospital acquires practices of some physicians who they may see as competitors. Does the executive leadership have an economic stake in the successful execution of the overall strategy? That is there incentive compensation tied in some fashion to the success of the physician strategy? Are the physicians in the owned practices clear about the strategy and do they buy into it? And if not, how can you achieve such buy-in? So those are the strategic issues. The balance of our program today is going to focus on the operational side, and so I'm going to turn it over to my colleague, Chuck Witter, to lead us through the balance of the program. Chuck?
Thank you, Bill. Let me start out by going through, of course, the fear factor and the information that we all are reading about, seeing on television, of where we're at in this financial situation with moving the healthcare system forward. There was a 209 information article that just came out in January of 12 that indicated by the Agency for Healthcare Research and Quality, our U.S. residents are spending about $1.26 trillion in 2009. 50% are accounting for 5% are accounting for 50% of the cost. And we're looking at the increasing healthcare expenditure now looking over a 10-year period of $938 billion. So that's what's keeping us up at night, wondering how to deal with this in our own organizations. And hopefully this webinar will give you all some tools that you can use to help solve this enormous financial problem. On the right hand of the slide, you can see what we've done is looked at sources of funds for Medicare expenditures from general fund and taxes, obviously the largest two pieces. The bottom part I want to talk just a little bit about because at the bottom of that, 13% physician services, and we're looking to try to fix the whole problem of controlling outcomes and utilization from physicians with 12 to 13%. So that's a huge task to account for. We're looking now at the Affordable Health Care Act, which has accountable care organizations, and recently, as April 10th, the CMS identified 27 ACOs that are formed to do the pilot study on this, 3 from Florida, 3 from New Jersey, 3 from North Carolina, 2 each from California, Texas, Massachusetts, single digits from Mississippi, Arizona, Kentucky, Wisconsin, and New Hampshire, and the biggest number of ACO formed was in the New York area at 5. So those will all be participating with the shared risk program, and we'll all be watching that closely to see what the outcome is, along with the Supreme Court decision, which you're all aware of will come about anticipated in June of 2012. We're concerned certainly about the Medicare sustainability, the reduction in reimbursement rates, increasing operating costs, recruitment and retention of physicians, and the regulatory compliance areas with START. Physician-hospital alignment models are certainly taking place now, and as Dr. Jessee mentioned, the increasing number of physicians moving to hospital employment models, and the list goes on and on. So I'd now like to turn my focus to some of these organizational structure and alignment models. Of course, we've had the professional service organization models in terms of a variety of those, in terms of outreach areas, just specialization PSAs, full practice PSAs, and then moving to more integrated employment models with hospital employment of single specialty groups and multi-specialty groups. With physician-hospital partnerships, we've certainly seen an increasing number of opportunities for medical directorships, lease agreements, joint ventures, and then moving to the more integrated models of co-management relationships, clinically integrated IPAs, joint ventures. What we've seen now, of course, evolving has been the medical home model to reduce CR visits and coordinated primary care, going back to what some of us who've been in the field for a long time known as gatekeepers. And then more recently, we're seeing more consortium models where there is a single legal entity and placing practice groups under that legal entity to gain leverage for benefits and health care with employees, and then third-party payer relationships. Decision-making examples of these various levels of the organization, Dr. Jessee mentioned certainly the buy-in by all three of these divisional operational areas, from boards of directors and hospitals, health systems, parent organization in charge of the overall responsibility. We certainly see a lot more performance-based accountability in administrative roles, not only from the administrator but CMOs of systems, down to the physician foundation governing level, policy level, with committing resources and making decisions from community assessments. And Tony's going to talk in the future of this presentation more about the importance of community assessments in this whole process. Clinical practice standard guidelines, I want to emphasize what we're seeing is a real disconnect in some systems where physicians are able to develop their own scheduling module versus having the system schedule for them, and that can certainly deter access and volume-driven patients into the system. And then the second most important one I'd like to emphasize, the EMR decision platforming. And what we're also seeing is even when the EMRs are in place, the frustration by the providers in terms of access to that, the speed of those systems, and when they don't have that kind of opportunity for continuum, the retraining piece tends to fall by the wayside. So we're looking at more retraining once providers are able to use those systems. And then finally, we get down to the departmental level of the organization, and we want to see clinical and administrative operation analysis. We're seeing more and a greater involvement of medical assistants replacing some of the LPN and RN roles to certainly decrease cost, and it seems to be working very efficiently in the outpatient clinic model. So at this point, I'm going to turn the revenue and operations profiling, which we do a lot of with practices, over to Tony to show you how we work that. Tony?
Oh, yes. So the revenue and operating expense profiling, as they say, is really the devil's in the details. So, I mean, really what we try to do is we'll dig into the information, and the first step of that process is really to restate the financial statements so that we're able to compare your information to the market standards and market norms. So, we'll look at the revenue, identifying the sources of income, looking at professional revenue as well as technical and ancillary services, getting into the expenses, breaking out benefits by physician providers, staff providers, and then really understanding each of those different components. There we go. And really understanding each of those various components. And so when looking through that, we're also going to understand the allocations as well from the corporate structure. As many of the hospital employed models, there is allocations coming from other areas, and you want to evaluate those as well. Another important factor is really what drives a lot of this information is really understanding the full-time equivalent FTE status of the providers. Some markets will look at just the physician providers. However, if you're in a rural market and you have nurse practitioners or physician assistants in your peripheries or operating your rural clinic, you're going to want to probably include them as well into our assessments as they're really acting as a full-time provider. Then when we take this information and profile you to the market. So here's just a snapshot of the various categories that we profile to. We do tailor our engagement to what the specific needs are of our clients, but for example, looking on top, there's advanced practice clinicians per physician FTE. We'll look at, over the right-hand side, looking at clinical support staff on a per physician FTE basis. We can dig deeper into those numbers, looking at staffing models, as Chuck had mentioned, looking at medical assistants versus LPN, and are they a better fit? And dig into a medical transcription, front office, and really figure it out on a per FTE basis, and also on a cost basis on a per physician FTE where you are relative to the market. On the bottom half of the slide, on the left-hand side, this is looking at the operating cost on a per physician FTE basis. But then if you also notice, it's very important that you're looking at operating costs relative to productivity. As you can see on the left-hand side, on a per physician FTE basis, the costs are below the 25th percentile. However, the clinic is so unproductive that you may find that your operating costs on a per work hour view basis are above the 90th percentile. So we do take a look at different types of snapshot measuring productivity and FTE basis. Another important factor is looking at your payer mix. You want to understand where your business is coming from as well as what sort of business is coming in the door. So, we'll look at your Medicare, Medicaid rates as well as your percentages. And we do compare you on a per charge and net professional collection basis, not only with market sources but as well as our internal database of information. One of the most important things I said earlier is start to understand where your patients are coming from. This is more of strategic analysis. You might want to look to see where your commercial patients are coming, where your lower reimbursement patients are coming. One of the things that this may affect is if you have a rural clinic, you may have to staff that more with nurse practitioners and other providers to help staff that as those type of patients may need more medical care. Whereas other areas such as pockets, looking at just on population density and where your age cohorts are coming from, not shown in these graphs, but you may have to have certain areas staffed by pediatricians as you may have a younger patient population cohort. So we're able to do a lot of mapping, look at median household income, population demographics, those sort of things to really help drive your strategic direction on where your clinic should be staffed or located. We're not necessarily coding and audit experts. However, we do a medical necessity and coding audit with outside counsel. These are one of the things that you really want to help understand are your providers coding appropriately. And as you know, family practice, you'll see that a typical office visit should lie around a level 3 visit. So we do look at that. We also look at the amount of time providers are spending with patients. Some of our markets that clients we've worked with, you'll have providers spending too much time with patients and helping educate them on what's appropriate and what's not appropriate. This is really probably a big piece of what we're coming to look at. In our experience in the current literature, A physician typically loses between $30,000 and $100,000 on a per physician FTE basis, and that's a healthy number to maintain per loss. And one of the biggest disconnects within organizations between boards and administrators and even clinic managers is trying to determine the factors that are affecting this loss on a per physician basis or per provider basis. And one of the things we'll come in and do is we'll look at physician productivity, we'll look at physician compensation. You know, the model, physician comp model may be a bad model. We'll look at the allocations from the system level, understanding how ancillary services are being transferred to the hospital and how that affects the loss, and then look at reimbursement rates and payer mix. One of the other things that you're not seeing on here that we'll do is to help educate administrators and board members is take the physician business and help attribute that to the hospital. So looking at the ancillary income, inpatient revenue expenses, contribution margin, as well as, like I mentioned earlier, the other ancillary stuff. So that's really looking at your operating expenses and your revenue profiling. Another huge piece, and which is actually part of your expense structure, is looking at physician compensation as relative to productivity. It's very important for us when we come in to understand the organization's compensation philosophy and understanding what drives the physician behaviors and provider behaviors in that community. And some of the things that we find that are good to have within a compensation philosophy is you want to pay competitively. And that means that when you recruit and retain a physician, or recruit a physician in your community, you may also want to be aware of what your competitors are offering as far as comp models, not just compensation. If that's a work RVU model, not professional collections model. You want to make sure you have internal equity, you're paying fairly relative to one another. You also want to reward for performance. As we're moving down and reimbursement is being tied to performance measures and quality, you want to make sure you're rewarding your providers for that type of behavior and helping them do behavior changes. You want to balance your financial reality. Many times physicians will put their, or administrators will put their physicians on work RVU models and pay really good rates. However, the net revenue that comes in to support the clinics does not support the high work RVU conversion factors. So it's important to understand your community and sort of your payer rates and how that ties in with your physician compensation. And then lastly, and quite importantly, is the regulatory compliance, making sure that your pay is within fair market value and commercial reasonableness guidelines. And so that graph on the right-hand side just kind of walks through, and when we look at physician compensation, we look at on the x-axis it's productivity, and then the y-axis is compensation. The idea here is a physician producing at the 60th percentile should earn roughly around the 60th percentile. And as I mentioned earlier, you can measure that productivity on not only a work RVU basis, but as well as a net professional collection basis. So in some markets, a physician may be working at the 60th percentile on the work RVU basis, but can only earn the 60th or the 40th percentile given the net professional and the reimbursement rates in that community. So it's important for us to look at both. But, we just for, illustrative purposes, in this case, we said physician A and physician B are both in the same model, comp model. However, physician A is above the line given the fact that it may achieve certain performance metrics or quality metrics. To continue with just some of the compensation relative to production examples, some of the things that affect compensation are governmental commercial payers. This would most likely affect a professional collections model. Practice operations would affect more so of a revenue less expense model. Physician community viability, there may be fragmentation in the medical community, as well as government Medicare guidelines regulations. One of the things I said earlier, these snapshots really help us determine where your physicians are being compensated relative to the amount of work effort they're putting out there. And just for some examples on the top left or right-hand side, physician A might be a physician only working at the 20th percentile in their first year. However, they may be a newly recruited physician in the community. They're placed on a 2-year income guarantee. They're strategically important to the hospital, and they may be responsible for developing/growing a service line of program. So in this case, in a commercial and reasonableness standpoint, these physicians can lie outside of fair market value range given these factors. On the lower right-hand side, physician B is on the professional collections model, produced in the 70th percentile area of the 40th. The reasons for this are they have lower reimbursement rates, not professional collections, and they may have an outdated compensation model. In some cases, you'll find that a primary care doctor is put on the same professional collection model as a specialist, and this can affect their overall payout rate given their level of productivity. Or they may just have poorly developed quality performance metrics. So these are a lot of the different factors that we look at when evaluating the physician compensation and productivity, and it's important for us to build this into our overall conclusions when we come in for our operational engagements. Just other snapshots to kind of keep going with the physician compensation and productivity is, again, we'll compare you to the market, national and regional. In this case, the top left-hand side is the cash compensation on a per FT basis. Right-hand side is measuring work RVUs, and then the bottom left-hand side is a comp for work RVU rate. So in this case, our physician is being compensated between the 75th and 90th percentile. However, they are only working at the 25th percentile on a national and regional basis, and then that lower left-hand graph means that their compensation per work RVU rate is above the 75th percentile. This does not match. However, again, to drive home the net professional collections and looking at not only that as well as work RVUs, if you look on a professional collections basis, they're actually producing at the 75th percentile, and this would justify a payout rate at the 55%, you can see in the bottom left-hand corner, which puts them between the 50th and 75th percentile. With that, and part of the things that drive a lot of these net professional collections, Chuck will talk about payer contracting and reimbursement rates.
Thanks, Tony. And one of the things that we're doing more and more of recently is working with physician groups, healthcare systems, hospital-owned physician groups, looking at their contracts. And I do most of that work for our group, and I can tell you right now that the contracts that we are seeing have not been updated or worked with third-party payers in the current market for some time. So we're seeing a lot of work developing relationships with payer managers, and there is a strategy to developing a good relationship with a payer manager so that you can get the most out of your reimbursement rates for physicians. I've also worked teaming with hospital administrators who have negotiating responsibilities and becoming a dual partner, looking at the physician contract portion of whatever agreements there are with the health system, and we would work in tandem. Oftentimes that works pretty well to get the maximum amount of reimbursement for both sides rather than trade off one side against the other. In those areas where we have strictly physician contracts, what we're finding is that they have not been renegotiated for some time, that they haven't used the appropriate strategy, and now third-party strategies are looking at breaking down the contracts in various areas such as the surgical codes, the imaging codes, the E&M codes, laboratory codes, and if you aren't familiar with benchmarking conversion factors for those different areas, there can be a distinct disadvantage for the organization and the specialist in gaining the maximum reimbursement rates that they should have. We're seeing payers at this point in time really trying to stay within 0 increases to a maximum of 2 to 2.5 when the cost of living is going up this past year about 3.6. So third-party payers are really trying to play all the cards that they can play to minimize the reimbursement rates for physicians. So looking at a strategy of experience in all the payer relationships, looking at the Aetnas versus the Cignas versus Blue Cross Blue Shield, and doing a comparative analysis, and that's really what this slide is showing, that one of the things that we will do is we will do a comparative analysis of all the contract payers that you have, and we're seeing about a minimum that you want to attain is 150% of Medicare. So we'll strategize and then place those on your current rates so that we can look at those and say to one payer or the other, we know what the rates are, and you're low in your E&M codes, and we need to go up 15% as an example, or you're low in your surgical procedure areas, and those really need to go up. If you take the next slide is kind of a national picture of codes, color codes, and you can see they're the ones that we have worked with and know of, kind of where they fit on the scale and if they have any opportunity for moving forward. These are percentage of Medicare rates now. Looking at the next slide, we're trying to show the evolution here of where we have been and where we are going, and what Integrated Healthcare Strategy has done is looked at moving forward on multi-year contracts, and sometimes you can negotiate better rates doing a multi-year, sometimes you can't. So we look at that. We also look at the conversion factor rates, and we have conversion factors that we've worked with for almost all of the specialties, knowing kind of where you should be on the conversion rate scale. We've, of course, moved away from more fee-for-service, moving to the value-derived payment models. There's a lot of data now needed for performance, and if your software does not provide you with good data in terms of PQRI, where you are in outcome measurements, I would certainly suggest, and one of the things that we would suggest as we come in is looking at better software. There's a lot of data provided now from national registries by specialty, and if you don't have that data in terms of negotiating third-party contracts, it's data that you should have. In addition, I would say that the big trick now used by payers is certainly to play one area of services off against the other area. So if you think you're negotiating a 2.5% increase across the board, my guess is you're not, and that the third parties will say, well, we've given you 5% in E&M codes, but if you look at your procedural codes or some of your subspecialty codes, you may not be getting anything at all, or you might even be seeing a decrease. So looking at that and making sure you understand what your payer is providing is a very important factor. The other thing I would say in terms of software support that we do not see is if you have a negotiated contract for X reimbursement and you're not looking at what your payers are paying, that's a big problem in terms of not getting from the payers necessarily what you contracted to agree to. So the next big aspect of looking at all of this operational areas is what is your community assessment telling you you need for providers? Tony?
Yes. This next section really, as we walk through the various assessments that we do, we'd like to point out that it's sort of like an a la carte. You can actually pick many of these to be done as well alongside the operational assessments. But I'm going to walk through the processes that we are going to do a full community healthcare needs assessment. Community healthcare needs assessments are no longer an elective process. They traditionally could have been called medical staff development plans, but due to the Patient Protection and Affordable Care Act, they're now required, and all non-tax exempt healthcare systems have to report that on the Form 990 that they complete these every 3 years, as well as have a strategy for going forward. And failure to do so does result in a $50,000 excise tax annually. Our approach to business research planning does combine a qualitative, quantitative assessment and to help really ensure that there's accurate and reliable information. Some of the things that our assessments can be used for is it can facilitate strategic planning, business planning efforts, develop strategies towards physician-hospital alignment, differentiate clinical service offerings from other competitors. You can identify advanced practitioner and clinician needs, and also really help determine if recruitment support can be given to independent practices in the community. The first step to performing a community health needs assessment is really understanding the community you're in, and that's a description of how healthcareization took into account, so looking at what sort of sources you use for your information, who you're talking to, which we'll get to, a description of existing healthcare facilities and resources in the community, and that's not only looking at what type of facilities you have as far as ambulatory surgery center, other outpatient centers, other hospitals and competitors, but looking at independent physician groups as well as physicians working for those facilities. And then you'd want to identify your service area, your primary and secondary, and once you do that, you can then really move into the second step, which is identifying the need. And part of this is identifying what the population is that you're servicing in your primary service area, and using that information to drive what the need is for each of the various physician specialties for primary care specialists and surgical specialists, as well as hospital-based specialties. We then take that information and we may have to use different demand ratios depending on your specific market. So looking at insurance types, is there high HMO, PPO mix, is there little or no managed care, and then also looking at local practice patterns, socioeconomic characteristics, as well as the local standards of care. The fourth step is really the quantitative piece. We're going to be adjusting those demand ratios, and not demand ratios, but the demand identified, and you're looking at the population, looking at physician recruitment patterns within the community. For example, given a recent recession, many older physicians decide not to retire when they were planning to retire, and these type of patterns are really important to build into our overall assessment. Looking at national, regional healthcare resource utilization trends, we all know there's more of a push of inpatient moving to outpatient, and orthopedics, not too far down the future, total knees and things like that will more likely be done in an outpatient setting versus inpatient with minimally invasive procedures. Looking at incidence of disease, heart rate or heart disease, those type of factors could affect the type of physicians you'll need in your community, as well as what areas of the community they're needed. Health risk factors, as we were talking about earlier, physician productivity. If you have a primary care community working at the 25th percentile, that's very different than you have a primary care community working at the 75th percentile and be able to recruit into that and understand your need. And then looking at out-migration, what type of case they're leaving. Many times we'll look at the emergency department logs and transfer logs and figure out what cases may be leaving the community or even be transferred to other facilities within the community. And I think another important factor I'd like to point out here is that we look at it on a FTE basis. We really drive into the FTE equivalent versus looking at a physician count and really helping affect our overall recruitment target needs. And then just, to the right side, just some of the graphics identifying, population demographics that we'll look at. And that bottom left-hand, or bottom right-hand side is, for example, when we're looking at different various clinics, it's sometimes good to look at what the productivity is for those physicians, and then coming into what we call maybe a virtual FTE, what is our actual needs to support that community on an average basis, market basis. And then lastly, and another important factor is really more of the anecdotal assessment. Really, we get into the community, we facilitate focus groups, work with public health agencies, private businesses, insurers, really help identify what the need is, what the gaps are. Conduct interviews with medical staff, administration, and other community representatives. Distribute a survey to the medical staff and advanced practice clinicians, and as you can see there on the right-hand side, that's just a few questions that we may ask. It's actually more extensive than this, but really trying to drive at what's causing the gap, or even maybe surplus in certain specialties within the community. Assess or perceived recruitment targets of regional physician groups. This is an important process to actually, if you have a robust, independent community physician, bringing them in the process and help understand where they're going. And then another big piece of this is looking at call coverage. Communities that we're working in today, this was a few years ago, you had neurologists not wanting or leaving the medical staff as they didn't want to do inpatient work because they were able to do financially better in their outpatient practice. And right now we're working in communities where rheumatologists and endocrinologists are also wanting to give up their medical staff privileges. And so this is another big piece. These health systems may need to recruit and employ physicians to fill this back, this need. So with that, and Dr. Jessee, Chuck, and I walking through these various areas, we'll go into questions And I do know that I actually have one question already, or we have one question already on what sort of survey sources we use. And when we look at the operational revenue survey sources, those are typically Medical Group Management Association, AMGA, National Consultant Business Survey, and then as well as our internal database working with different clients and different types of, especially group sizes and those type of things. And then, when we look at the compensation productivity, we actually integrate healthcare strategies, provide medical director surveys. We also use MGMA, and then Sullivan Cotter Associates. Our secondary sources, for as far as physician recruitment, we may use Merritt Hawkins. So we do have quite a few survey sources we use there, industry-specific sources for oncology, cardiology. And again, I'll reiterate the fact that we have a since we do a lot of fair market value assessments and commercial reasonableness, we do get a lot of physician information for clinical co-management agreements, professional service agreements, employment agreements, and all that goes into our internal database as well, just to verify our numbers.
And I will say I'm working with a large anesthesiology group, and we will use association information where they do survey of their membership every year on a variety of compensation and benefits and call, et cetera. So that we do have more than just the standard survey data available to us for specialty and subspecialty needs.
Great. Thank you, Chuck and Tony, for answering that first question that had come earlier on for one of our participants. First, I want to go ahead and thank all three of our presenters this afternoon for all that great, thorough information that we've packed into 45 minutes here. I do have a few other questions that have been coming through. Before I start moving to those, I want to remind all our participants, in case there's anybody else who would like to quickly submit a question, how they can do that. Again, you just simply go to that Q&A button on the menu bar at the top of your screen, type in the question, and then just click the submit button. I'm going to go ahead and refer to a question from Kathy here. It says, have you seen a pooled incentive compensation bonus structure in a specialty group, like a cardiology pool use their RVUs and compare against pooled RVU calculations?
Yes, absolutely. A lot of times, when you bring a cardiology group into a health system, they want to have a lot more autonomy over the control of their compensation structure. And so a way of doing that is to, first of all, make sure that the pool of dollars being provided to that group is within fair market value, given the level of productivity and all the other facts and circumstances. But really helping them drive sort of how do they want to split the pool. Is 50% of it going to be on a per FT basis and 50% of it tied to work RVUs and productivity? So to answer that, yes, and also I think more importantly is not only factoring in productivity and allocation methodologies, but also incorporating clinical management, quality performance type things into that compensation pool and really making that more of a piece and help drive physician behaviors in that area.
And I think we've been seeing more in the outcome measurements, quality measurements feeding into that example as well.
Great, thanks,
Just to add a comment, I think how well the pooled compensation program works depends a great deal on the culture within the group. If you've got a group where all the physicians get along, everybody's happy with saying, we all benefit when the group does well, then the pool compensation arrangement can be very beneficial. But if it has the potential sometimes to open up veins of jealousy if you don't have if it's not perceived by the members of the group as being fair to them. I'm a high producer. Why don't I make more money?
Thank you, Bill, for adding that. I have a question here from Richard who asks, for clients with broad market reaches encompassing different payer profiles, how do you recommend reconciling internal equity with balancing internal equity? Do you recommend a blended rate or compensation by pod? Let me know if you'd like me to read that again.
Yeah, read it again.
I'll read it one more time. For clients with broad market reaches encompassing different payer profiles, how do you recommend reconciling internal equity with balancing internal equity? Do you recommend a blended rate or compensation by pod?
the question here really is, are we paying physicians fairly across the system versus allowing physicians in different community or different areas of the community to pay differently? I think going even to Dr. Jesse's comments, it's really the culture of the physician community, and I think it would be appropriate to pay either way, depending. I think where we're going as far as, as Chuck had said earlier, when we look at organizational structures and the way the management structure is for clinics, I think it's very important is to start getting down to the pod level and having pods have more control and access over their compensation structures, and really with that, those physicians in those pods, or even as we're going to more clinically integrated models, where there's a dyad where administrators and clinic managers are working with physicians at various levels, driving those decisions based on the culture of that particular group of physicians.
Yeah, I think if we were to do an engagement with the organization asking that question, we'd probably come in and do an assessment first of how that culture works and where the touch points are, and then depending on that, maybe design 2 systems of each and then float that by the organization and physician leadership to see if one were to shake out better than the other.
As you can imagine, we've seen both.
Okay. Bill, do you have anything else you'd like to add?
Nope, I think that's covered it.
Okay, great. Just want to remind everybody, we did block this webinar for a full hour, so technically we have about another 15 minutes, so I'm going to go ahead and keep taking a few more questions as we round out our time. Next question I'll read off here is, what does our firm see as standard third-party rate increases, and what should we tie the increase to in the contract?
Well, as I said earlier, what we're seeing in contracts for physician services is somewhere between 0 and 2.5%. And what you should tie those rates to is looking at each one of these specific areas of E&M codes, procedure and surgical, laboratory, and imaging, because the third parties can tend, and what we've seen do tend, to move in one of those areas or multiple areas to provide more reimbursement than the other. And the way they do that is they tie that to their own philosophy and what they've done with other contracts. And it's a negotiating strategy that you just have to bear with, and you have to have good relationships with the managers of the contract network. And that's more important than anything. If you start to push too hard, they will push back. And what I've seen is they will say, I'm not going to provide those rates to you, and we will immediately send letters to all your patients saying you're not participating any longer. So if you get to that stage, you failed in your negotiating strategy.
Okay, nothing else to add. All right. I'm going to go ahead and take our next question from Michael here, asking, well, what does integrated healthcare strategies see as a trend in conversion factors, and do you have any benchmark data?
The answer is yes, we do have benchmark data for almost all of the specialty and subspecialty providers, and we are constantly updating that. What we see is trends. Again, I will tell you that the 150% of Medicare seems to be what all of the payers are moving toward or hanging their hat on staying with. And our objective is obviously to raise that any way we can by overall or by looking at the various service models, as I mentioned before, with imaging, E&Ms, or procedures. And multi-year is the other thing. If we are able to sometimes develop a multi-year agreement, we can certainly sometimes increase the overall reimbursement rate, but that depends on payer to payer.
Okay, thank you. I'm going to go ahead and take just one more question here because we do have a few closing comments before we wrap up. This looks like it's a pricing-related question, so we'll see if it's a cut and dry answer for that or not. What is the cost of a typical operational review for a physician practice?
Well, it depends on the physician practice, obviously. What we would look at is kind of a number. If we were dealing with a small group per physician, probably $1,500 per physician. if we had 4 or 5 physicians, you could multiply the 1,500, and that would be probably pretty close to what our rates would be for a complete analysis, assessment, and report.
Okay, sounds good. Hope that answered their question pretty good. With that, like I said, I'm going to go ahead and close the Q&A here. If there's any additional questions that we didn't get to, or if you think of any after the fact here, I have contact information up on your screen for our 3 presenters. You can call or email them directly and have some further discussions with them if you'd like. I want to thank all the participants for making time to listen in today. As noted, we will be sending out a copy of today's presentation slides in the near future, and also in the next few days you can visit our Knowledge Center on our website at ihstrategies.com to view a playback of the recorded webinar. Also, if you noted in your registration that you would like to receive an official certificate of completion for this event, you can look for that to be delivered to you in the near future as well. Keep an eye out for any of our upcoming webinars, and we hope you'll join us again soon. Thank you and have a great day.